So I just wanted to go over the agenda real quick. We did schedule the meeting for 2 hours. We know that's a fairly long meeting, so we might not use the whole 2 hours. We just wanted to give us enough time just in case. We've got a lot of exciting topics to go over. So we're going to start out with a quick introduction to Comagine Health. We know not all of you have worked with us in the past. We have been in the Las Vegas community for over 30 years, formerly Health Insight, but we did want to just give you that quick introduction to Comagine Health. Then we'll start off by going over some Southern Nevada community information. So we'll talk about the demographics, the population in Southern Nevada, and then we're going to want to go over some of the health indicators and disparities that we've seen through the literature, a lot of the community health needs assessments from the health district and from a lot of the other organizations had a lot of great info. We won't spend too much time on that because we know you're all community in the community and you know what a lot of these issues are, but we really want to hear from you on what issues and health disparities you're seeing in the community and possibly how this Pathways project can be a help there. So as we're going through those disparities, please kind of keep in mind things that you're seeing in the community, and then we'll go to a breakout session where we can talk about those. We're going to break out into 5 groups, and we'll have some Comagine team members in each of the 5 breakouts to help guide that discussion. From there, we'll move over to CommonSpirit Health and Brian Lee. He's going to talk about CommonSpirit's investment in the Pathways Community Hub model. And then we will have Dr. Sarah Redding, who is the founder of the Pathways Community Hub model from the Pathways Community Hub Institute in Ohio. And she's going to give us an in-depth overview of the Pathways model and allow time for questions, and we'll break out from there as well. So we will break it up, but as you're going through, any questions you have, just please put those in the chat and we'll make sure we hit on those when we stop for a break. And then we'll finish it off with Comagine's goals for 2022 and what's next from there. And we'll have some time at the end for discussion. All right, Lily, next slide, please. So just wanted to start off by introducing the Nevada team for Comagine Health. So we have a couple folks in our Las Vegas office that we'll introduce, and then myself, I'm Brian Parrish. I'm located up in Reno, but I'm going to serve as the hub director for Comagine Health as a senior improvement advisor. Tracy Carver's on the call. She's our senior director of community health. Many of you may have worked with Amy Schmidt in the past. She's located in our Las Vegas office, and she's our Nevada state director. Dr. Jerry Reeves is also based out of our Las Vegas office, and he's our medical director. We've got Lily Mazmanyan as an improvement advisor and Manny Hinojosa as an improvement advisor as well. Thanks, Lily. Next slide. All right, so if everybody has a cell phone handy or wants to grab it real quick, we've got a quick little icebreaker that we can use text messages for. So if you can answer in one word, what motivates you on improving community, what motivates you to work on improving community health, you can text that answer to 22333. So that's the number you're going to send the message to. And then if you enter that code 195928 in your word, you'll send that to the 22333, and it's going to help us populate a word bubble like you can see on the right side of the slide there. We're going to leave this up for about 30 seconds or so to allow folks to send that message in. But just to repeat, you're going to send the text message to 22333, and in the body of the text, it will be 195928 in your word. So I know this can get a little complicated, but it does create a cool little activity there. So that way we can see what's motivating folks to work there. And I'm going to do it myself now. So if you see me looking down on the phone. Perfect. And you'll see this start to populate as the messages come in. So just a good way to see what motivates people to go to work every day. And as these words get bigger, that means more people are sending in the same word. So the largest words are the ones that are the most common there. And thank you to everybody who's putting their name and agency in the chat. We appreciate that. Looks like we got a great turnout, over 80 people. All right, and it looks like the poll is full, Manny, so we can go ahead and go back to the PowerPoint, please. Thank you. And Lily, you can go ahead and go to the next slide, please. Awesome. So we have three main meeting objectives for today. The first and most important is we want to create a dialogue about Southern Nevada's most pressing care coordination challenges and opportunities for improvement. So we really want to hear from the community. We know most of the representatives on this call are based in Las Vegas and are working on community health in Southern Nevada. So we really want to hear from you on what you're seeing as the biggest needs in the community as well. We also want to orient partners to the Pathways Community Hub model as an evidence-based approach to improving care coordination. And facilitating access to social services and support systems as well. And then the last one, we want to invite partners, so everybody on the call, to join us in developing the capacity to implement this Pathways Community Hub in Southern Nevada. So this is not something that currently exists in Southern Nevada. We're working on building the capacity for it and wanted to gauge community interest, and that's why we invited you all to the call today. So we really want to hear from you. We appreciate as much participation as possible. Thanks. And Lily, if you could go to the next slide, please. And I'll turn it over to Tracy.
All right, thanks, Brian, and thanks for starting us off on this Monday morning. Nice to see you all and meet those of you I haven't had a chance to meet. I wanted to just share a little bit of background about who we are in case there are folks in the room that maybe are less familiar or perhaps haven't engaged with us in a while. So we are a nonprofit quality improvement organization. And we actually have very deep roots in Nevada. We've been here for over 30 years, and we wear lots of different hats. We do a number of federal and state initiatives. You may have known us and prior interactions as the CMS QIO, or Quality Improvement Organization. So that is one hat you may have interacted with us under, among others. And we do our work. We are a nonprofit, and really our focus is to work with community partners as a trusted neutral convener and collaborator to understand, prioritize, and address complex health needs. And Lily, if we can go to the next slide. Great. So I just wanted to set the stage a little bit for the conversation today before I hand it back to Brian. And what you see on this slide is a very high level, if you will, kind of representation of the things that drive our work. But as it relates to what we're here to talk with you all about, as we all know, the system of care coordination in Nevada and really in many states is siloed, and kind of the current state of affairs. There's a risk that patients are falling through between the cracks as they roll on and off health insurance, or between plans, between healthcare providers, and even between social service delivery partners. And so when we were kind of approached to start this community dialogue, we were pretty excited about it because we see that there's a lot of important work and opportunity to really improve care coordination in Clark County. And Brian's going to share in a moment some more data that I'm sure will not be necessarily new to you, but really that I think demonstrates the opportunity that we have to take a closer look at how we're working together and evaluate whether this evidence-based approach, and with support from Comagine Health, we can make some improvements. So the other thing I just wanted to note is that we've had success in other communities doing work around care coordination and really improving how community partners are working together to improve the health of our patients. And so we were just very excited for the opportunity to bring this dialogue to you all here in Clark County and go down this road together. So I am going to hand it back to Brian now.
Thanks, Tracy. And Lily, you can go ahead to the next slide, please. So for this first section, we just wanted to start with a community overview. Many of you live and work in the community, so we don't want to tell you things you already know, but a lot of this is important in the context of the project that we're working on here. So I just wanted to start with a quick overview of the population. As many of you know, the Southern Nevada, specifically the Las Vegas community, has been booming for many years now. Nearly 300,000 or 320,000 people moved to Clark County over the last decade, bringing the population up to 2.3 million. That's up from 1.95 million, so a 16% increase. We wanted to put this chart on. I know it's a little bit hard to see in small, but over the past 10 years, you can just see how much the population has skyrocketed. We just think this is important, that we know the community has been blossoming and blossoming, but the resources don't always keep up with this rapid growth. It's harder for healthcare and social services resources to keep up with growth at this rate. It's not something that's easy to accomplish there. So go ahead, Lily, next slide. We wanted to talk a little bit about the demographic breakdown, and some of this is back from 2018. We know there's a little bit of a data delay with everything going on with COVID-19. So some of this is pre-COVID data. So we just wanted to put that out there. But you can see the Clark County community, it's the most diverse county in Nevada as far as representation from different race and ethnicities. You can see we've got a 30.9% Hispanic and Latino population, and the majority of Clark County is non-white minority populations that make up the county there. We also wanted to highlight some of the poverty disparities amongst race and ethnicities. You can see the Black and African American community, 24.7% below the poverty line, and American Indian, Alaska Natives, 25%, Hispanic and Latino, 18%. All three of those are much higher rates when compared with the other race and ethnicities. The median household income for Clark County of 56,000, that's much lower than the national average in the US, is over 60,000 now. We wanted to highlight that as well. We know Clark County has some disparities, especially when comparing to the national averages for both social aspects and for health aspects as well. And if anybody, I know a couple of you have interest in the slide. So a lot of these have come from the multiple community health needs assessments that have been done for Clark County and Nevada as a whole. So you'll see a lot of data from different sources here. And we just tried to go through all those, highlight some of the common themes there. And go ahead, Lily, we'll go to the next slide. One thing we wanted to really hit on, and we're sure you're all aware of this, is the COVID-19 impact, specifically in Southern Nevada. The unemployment rate in Southern Nevada was one of the hardest hit throughout the whole nation. So you can see on the graph to the right there, March and April of 2020, they actually got over, I believe it was over 28% of unemployment for Nevada. And we know that when people are losing their jobs, oftentimes they're losing health insurance as well. So that's why we really wanted to highlight that. For 2021, Nevada had an unemployment rate of 6.8%. Which was 50th in the nation. So we know we are behind a lot of the other states when it comes to unemployment. Much of those shutdowns in the casino industry in early March 2020, April 2020, we know that affected a lot of folks in the community, and you're probably all well aware of that. But we're just interested in looking at that could potentially affect healthcare access going forward for the next couple of years as well. Lily, go ahead, next slide. So as we mentioned, healthcare access was one of the common themes throughout all of the community health needs assessments that we looked at. In 2020, 13.7% of Clark County adults aged under the age of 65 were uninsured, and that was much higher than the national average as well. You can see that the Hispanic and Latino community was the hardest impacted with lack of health insurance, nearly 30% uninsured there. 21.4% was back in the 2018, but we know that throughout the pandemic that did get up to almost 30%. And go ahead, Lily, we'll go to the next slide. Some of the indicators we wanted to look at related to chronic disease, coronary heart disease is the leading cause of death in Clark County, and that's pretty consistent with the rest of the nation. So we know that's a similarity nationwide. But one thing we wanted to highlight were some of the zip code level data that we were able to find. You can see that the 89039 zip code had almost 15% as compared to 5.8% for the county as a whole. And we were slightly higher than the national averages as well. But we did notice that there was about 4 or 5 zip codes there that were nearly double or triple the average for the county. So that was one thing that we wanted to highlight. Go ahead, Lily, next slide. Obesity and overweight, we can see that there's 37% of Nevada adults were considered overweight and 30.6% obese. So combining those two, that's over 67% of the population in Southern Nevada considered obese or overweight. And you can see the trend on that graph is not something that is looking great. It's been going up pretty consistently over the past 5 or 6 years. And we anticipate that is going to lead to some chronic health indicators down the road. We all know that obesity and being overweight can lead to diabetes, high blood pressure, things along those lines. So we are concerned about that trend. Lily, go ahead to the next slide. Maternal child health disparities. There are a lot of disparities in the Southern Nevada community that we've noticed throughout the multiple community health needs assessments. One of them being the teen birth rate. So the chart on this slide, you can see the teen births by race and ethnicity, and there's a large amount of disparities for the Black and African American community there, 38.9% as compared to 12.1 for the white and Caucasian. That's a pretty massive disparity there and something that's concerning. Throughout a lot of the community health needs assessments, we know maternal and child health didn't get identified as a lot of the target areas there. A lot of those, they kind of lumped maternal child health into the healthcare access section. So it is a spot that a lot of the community, the Pathways community hubs in other locations through other states have focused on maternal and child health. So that was one area that we wanted to highlight. Lily, go ahead to the next slide. Thank you. So for this one, we were going to highlight the babies born in Clark County that were preterm, 10.9% of the total in 2019. And again, you can see the disparities amongst different race and ethnicities there. So Black African American at 13.7%, and the Asian Pacific Islander population in the 11s, as well as the American Indian Alaska Native population in the 11th percentile as well. Clark County also had a similar proportion of women receiving late or no prenatal care compared to Nevada as a whole. So they were higher at 8.4%, and both the state and Clark County were higher than national averages, which was about 6% there as well. We also found that there was some large disparities related to maternal education. 30.3% of Hispanic and Latino women reported less than a high school education, so those mothers, and that's an indicator for healthcare down the road as well. Lily, next slide, please. So the couple areas for infectious disease that we wanted to take a look at were both HIV and syphilis specifically. We know there's been some disparities in the Southern Nevada community there. From 2016 to 2018, HIV rate in Clark County was 21.5 per 100,000, which was much higher than the national average. And specifically, the Black and African American community had a rate of newly diagnosed HIV cases at 59.9 per 100,000. So you can see on the graph, there's a really large disparity there. American Indian population also had a pretty high rate there as well when compared to the other race and ethnicities. Clark County also has higher infection rates for chlamydia, syphilis, gonorrhea, all higher than the national averages. So that was an area we wanted to take a look at. And Lily, next slide, please. Thank you. So Nevada did have the highest rate of primary and secondary syphilis in the nation for 2017 and 2018. We wanted to share this graph on this slide because you can really see over about the past 10 years now, there's been a pretty stiff increase on syphilis cases. We know that there was the outbreak during the time of 2017, 2018, which contributes to a lot of the spike, but it's still continuing. It's not really dropping at the rate that we were hoping to see for Southern Nevada. So we just want to highlight that is an area of concern for the community. Lily, next slide, please. So for the Medicare population, we wanted to take a look at a couple of outliers that we saw. Comagine Health has access to some of the Medicare and fee-for-service data. And we saw that Clark County had the highest rate of hospitalizations for beneficiaries identified as superutilizers and of hospital readmissions within 30 days. So those are folks who get out of the hospital and then are readmitted within a 30-day period. And Lily, next slide, please. So these stats on this slide are comparing us to 44 other geographic regions, and they're all in the western and southwestern U.S. So Idaho, New Mexico, Nevada, Oregon, Utah, and Washington are the communities that we're being compared to on these data sets here. So you can see we rank 44th out of 44 for the 30-day hospital readmission rate. So we know there's a ton of room for improvement there. We also ranked 44th in the superutilizer category. Cardiac rate event, we were at 40th out of the 44, diabetes prevalence 36th, and chronic kidney disease at 40th. So these are 5 of the areas that we really wanted to highlight where we have a lot of room for improvement in Southern Nevada, and we'd love to hear from you folks as we get into the discussion and breakout here coming up about some ways that can be improved or ways that you guys have seen community health workers being involved in some of this. Lily, next slide, please. So this is that from that same data set, but we wanted to take a look at it by different rate, by race and ethnicity. So you can see the Black and African American community was one of the most impacted there, as well as the American Indian and Alaska Native. So they were both over 100 compared to the other races and ethnicities, which were much lower. So that was one area we wanted to take a look at. And Lily, go ahead to the next slide, please. So we wanted to pause here after going through some of the areas that we found throughout the community health needs assessments. We know that's not all of the disparities in Southern Nevada, and we don't want to be harping on Southern Nevada as, not being up to the national standards on some of these, but, this is the community that we're all living and working in. So we want to hear from the folks who are on the ground and see what factors or issues that you see impacting health in Southern Nevada. So anything you can put in the chat or save for the breakout session, we'd love to hear from you. We also wanted to look at what opportunities you see to improve care coordination. As you could see from some of the data that we shared, care coordination could be struggling a little bit with all those readmissions that we're having. So maybe folks aren't getting the proper guidance as they're leaving, or maybe the resources aren't there for them. So we'd love to hear from you on that. And also how your agencies are currently using community health workers to address community health needs. We know community health workers, there's been some recent legislation in Nevada that really highlights the importance of their work. So we'd love to hear what your agencies are doing in relation to community health workers, and maybe how that can be implemented in the future. So I'll pause. Any questions in the chat or anything we'd like to bring up before we get into the breakout session? All right, so what we're going to do here is we're going to break up into 5 randomly assigned breakout groups, and we're going to have some Comagine Health employees in each of the 5 sessions just to kind of help us facilitate the discussion. So Manny and Lily, if you can go ahead and break us up into those sessions, give us 1 minute to get set, and then the Comagine employee will help kind of put these questions back to the forefront there. We'll do that for about 10 minutes, then we'll bring everybody back to the group and have a little debrief. Thank you. See everybody returning back to the meeting. So thanks for participating in those breakout sessions for us. We appreciate it. I'll give everybody 1 more minute to hop back in. Awesome. Thanks, Lily. All right, so we just wanted to do a quick debrief on the breakouts. So I'll go around from group to group, and if the Comagine team who were in those breakouts could give us a little debrief about what your group talked about, we'd appreciate it. I can start with Tracy.
All right, thanks, Brian. Yeah, we had a great conversation. So just a couple of key themes I think that really stood out. One was we had a couple of community-based kind of social service or other kind of service and supports partners in our room, and they definitely identified the need for a mechanism to receive referrals from their healthcare partners to ensure that their services were reaching the people that need them most. We also identified that supportive and kind of long-term supportive housing was a significant need. And our group also talked about populations that perhaps wouldn't get to their services otherwise. So we had a representative from the food bank in our room that sort of talked about, there are a number of mechanisms or ways in which people get to the food bank, but that there are populations, and notably seniors, people with disabilities, who perhaps wouldn't be coming to their services, or that could get, wouldn't necessarily be identified as quickly as optimal in the current environment. In addition to the supportive housing, we talked a lot about kind of need for mental health services. One of our partners identified or shared, that they see folks discharged and kind of receiving some short-term follow-up, but then they are sent back out into the community and without any additional supports, and saw a real opportunity in that space as well. And then we did hear a little bit about the use of community health workers at Southern Nevada Health District, and it sounds like there are some nice examples out there of ways in which community health workers are already working in the community. So I will stop there, but I have copious notes for the team for later.
Thanks, Tracy. Amy, do you mind going next?
Yeah, sure, no problem. A lot of the same themes that Tracy hit on. We also talked about infant mortality and teen pregnancy and how that connects to mental health issues as well in the community, as well as the housing crisis. Tracy touched on that as well. The difficulty applying for services and the stipulations for qualification, and also just the technology piece of it being difficult for people to apply and finding different ways for them to do it and using technology to help assist with that. Capacity was a big topic that we talked about. Clark County Social Services brought that up. Just having enough folks, personal care attendants, to do the work. Capacity and housing, again, a huge issue. And then also the ability to connect to other resources in the community. You might have community health workers focus on medical care and finding a medical home and assisting with things like medication, but they're more of an opportunity to connect in the community for other social service resources that are out there. Increasing accessibility, again, that more virtual connection. Some agencies not using community health workers, but looking for opportunities to use community health workers because they've seen that in other communities work really, really well to improve outcomes. And then also folks doing a really good job. Again, the Southern Nevada Health District and Dignity Health and their HIV programs came up specifically. And then poor Richard got cut off at the last minute because we had such a robust conversation. We couldn't finish his thought, but I will reach back out to you, Richard, I promise, and lots of great notes. So thanks everybody for the good conversation.
Great, thanks, Amy. I'll turn it over to Dr. Reeves next.
Ours started out with the discussion of pregnancy, high-risk pregnancies, combined with substance use disorders that is adversely impacting outcomes. Also post-acute care after folks are discharged from hospital, coordinating the care after discharge, access to insurance and to care providers because we have severe shortages of healthcare workers in Southern Nevada. Legal issues, especially end-of-life types of legal documents and legal support for frail elderly populations. Access to care and insurance, especially by our large number of undocumented persons in Southern Nevada, and the complicated issue of navigating folks around the multiple sites of care for their multiple chronic conditions. We have severe workforce shortages and need to leverage additional well-trained community health workers to help optimize the workforce shortages that we have. We need better collaboration between the various islands of expertise and experience, because a lot of times the expertise is working very hard in their own silo, but there's not adequate or appropriate or optimal handoffs when people need more than just one particular discipline for types of services. Very rich discussion, took lots of notes, recorded our discussion. There's lots of rich information here to work from. So thank you all for your contributions.
Thanks, Dr. Reeves. And Lily, did you have your own breakout group? I didn't want to skip over you as well.
I did. Unfortunately, we didn't have that much time because I got moved from one to another, but we did have a communication. We did talk a bit just with the first bullet point, echoing a lot of what everyone else said, but definitely readmissions being an issue, need better communications and resources, follow up with people that are discharged. So they don't get readmitted. So we heard that lack of providers, nurses, physicians, assistants that are needed, especially with COVID and getting worse. We heard healthcare. We need better healthcare promotion with different ethnicities, targeted towards different ethnicities as well as ages. Access to healthcare, and we also heard we need more innovative points of access, being creative in the way that we're putting out our messages.
Great, thanks, Lily.
Yeah.
And I can speak to the last group, and if everybody can mute themselves, if you don't mind, or Manny, if you could help out with that, appreciate it. I think you guys hit on most of what we talked about, but we did have Amina from the Southern Nevada Health District talk about the barbershop and beauty shop initiatives that her team is running. And that was a really interesting project that's going into the barbershops and beauty shops in Southern Nevada and connecting with folks, doing blood pressure screenings, helping them connect with care. And that's just a really good example of how these community health workers can be used to develop one-on-one relationships with the specific population. So I thought that was really interesting to hear. We also heard about individuals with disabilities and how it can be really hard to navigate our healthcare system with certain disabilities. So the community health workers being used for those purposes as well. And I think everything else you guys kind of already hit on, so I won't rehash that out. But we really appreciate everybody's participation in that. I think we got a lot of good information there. And from here, Lily, if you want to move on to the next slide, we can go ahead and turn it over to Brian Lee with CommonSpirit. Brian, thank you for being on the call with us today and being willing to talk for a little bit. We appreciate it.
Thanks, Brian. And hi, everyone. What a great breakout session. It's really great to hear about what is needed in the community. I'm Brian Lee, a director of Community Health Strategic Initiatives at CommonSpirit Health System Office. In 2019, Dignity Health and Catholic Health Initiatives merged to form CommonSpirit Health, a health system that has over 140 hospital facilities in 21 states. And for many years, we've been working closely with the Nevada's Community Health Dignity Health team to address social determinants of health, and have found many challenges working with vulnerable community members in an efficient and effective manner. Most of the time, we saw what you all mentioned during these breakout sessions: a lack of community capacity and resources, lack of standardization in processes and data, and then seeing a lot of duplicated efforts between health entities. So in March of last year, we partnered with Pathways Community Hub Institute to introduce their model in 5 of our hospital communities, one of them being Southern Nevada. As you can see from this slide, there are many benefits to this model, such as having a centralized entity to create structure on providing navigation services to community members. Next slide, please. The other pieces that we believe are beneficial to the community include access improvement by utilizing community health workers who address health equity through compassion. 2 big callouts we heard from all of you earlier today: the ability to mitigate any risk for the rising risk population, and how this model standardizes processes and reduces inefficiencies to deliver quantifiable outcomes. So we're really excited for all of you to learn more about the model today. And I'll hand it over to Dr. Sarah Redding, the founder of the model, to take you through the journey and learn more about it. Thank you.
Thanks, Brian. So I'll go ahead and just introduce everybody to Dr. Sarah Redding from the Pathways Community Hub Institute. She's the founder of the Pathways Community Hub Institute, and for more than 30 years, she's worked with community health workers across the country, developing educational programs and providing training. The PCHI model is designated to transform communities through improving outcomes and for those most at risk. Dr. Redding completed her specialty training in general preventative medicine at Johns Hopkins University, and she's going to talk to us about an in-depth little overview of the model. So we appreciate it, Dr. Redding.
Thanks, Brian. Lily, we could go to the next slide. And I want to go back a few steps and talk a little bit about how we even came up with this model in the first place. That's, we weren't just sitting around one day thinking, let's do a model. My husband and I spent time in Kotzebue, Alaska, above the Arctic Circle, and that was our first encounter with a community health worker. Had never heard the term before, had no idea what they could do or how to use them, because we weren't trained on that when we went through our medical training. But by the time we left Alaska and moved to Baltimore, really didn't know how we were going to do our work without a community health worker. It just seemed like this insurmountable task. I was fortunate in that I was able to work with the Baltimore City Healthy Start program at the time, and they were using community navigators, very similar to CHWs of today. And we did a lot of great things. We, had a great group of women. We had college level training for them. We were in the right communities to be served. But I watched what happened when the grant funding went away. And who do you think were the first people to be let go? The CHWs. So we had spent all this time and all this effort, and we were really seeing good impact, and they were the first to let go. And back then, there really wasn't a lot of other opportunities to move into if you were a CHW. It was pretty specialized at that time. So when we moved back to Ohio, where we're originally from, our first inclination was to not do anything with CHWs because it was really frustrating, but realized from the experience in Alaska that, CHWs were just too important to let that concept go. So we started the Community Health Access Project based in our own county in Ohio, really with just the mission of, could we get CHWs to work with high-risk pregnant women? So the next slide is actually a picture of our very first group of community health workers. Great group of women. They were already involved in their churches and community-based organizations. We had great training through our local community college that we developed. We did hot spotting before anyone thought to call it hot spotting, but we knew where the poor birth outcomes were happening. And they did their work. They went out to serve the high-risk pregnant women in our community. But when we looked at our data about a year and a half in, we weren't making a significant impact. We had a lot of good stories, but it was really hard to evaluate the data that we were collecting. And looking back now, it was unfair to put community health workers into such a fragmented system and think that they were going to be able to fix that. So that was our first big lesson learned, is that it took more than just putting CHWs out there. Our first development was actually creating pathways. In our model, pathways are a tool that the CHW uses to measure every time they identify a risk factor that's modifiable from identification, track through to mitigation or elimination. So pathways were our first kind of development in this model. The next slide, our CHWs taught us really early on that we could not do this fragmented approach anymore. We were physicians coming with a very medical focus, and we were taught by our CHWs that you got to get people housing, you got to get them food, and you got to get them jobs, or their healthcare is not going to get better. So the next slide is where we are today, where we approach everything with whole person care, that no risk factor is more important than any other risk factor if it's getting in the way of a good health outcome. I'll show you a little bit farther on some of the data from that original study of using pathways, but we were seeing a big impact suddenly. And that was great, but we were one organization in a very large county, and we weren't going to get to health equity through one organization. And I'll make that argument, no matter how large of an organization you're representing, it's going to take the community. It's never going to be one hospital system or payer or state agency. It's really got to be the whole community. And out of that evolved the Pathways Community Hub approach. The next slide gives you a working definition of a Pathways Community Hub, and we'll break this down. But the Pathways Community Hub is an organized, outcome-focused, pay-for-performance network of community-based organizations and others that hires and trains community health workers to reach out to those at greatest risk, identify risk factors and barriers, and assure connections to medical, social, and behavioral health services. And we'll talk through each of those parts. The fascinating thing is that Pathways Community Hubs start out by addressing individual risk factors, but by addressing those, we start to see community level change. And we employ a quality improvement framework in that work. Pathways Community Hubs also have outcome-based payment. It's the only model we're aware of with community-based care coordination that has that in place. But it's a way to build sustainable funding for the workforce doing this work. And what we've been able to show is that a certified Pathways Community Hub not only improves health, it reduces costs and promotes health equity. So the next slide is just giving you a picture of who can we serve with the Pathways Community Hub. And so far, we have not found any population we couldn't serve with this model. Clearly, all of our Pathways Community Hubs are working with COVID-19 right now. Some are focused more on maternal and child health, some more on chronic disease, some on criminal justice. Many of the mature Pathways Community Hubs deal with multiple populations at the same time. The next slide is a visual of a Pathways Community Hub. So PCH is our abbreviation, and the Pathways Community Hub is in the center there. It's the dark blue circle. A Pathways Community Hub is small. Usually when they first start out, they're only 3 people on average. But what a Pathways Community Hub is doing is going out and recognizing all of those community-based organizations, federally qualified health centers, other agencies and organizations that could employ community health workers either are employing them or are willing to employ them, and contracts with them to form a community-based care coordination network. So the hub comes in and puts the infrastructure in place. All of those organizations were existing before. The hub just brings them together into the network. The most important part, though, of the network is the circle to the left with the community health worker and the family being served. Whatever we do within this model, we recognize that is the most important relationship, and we don't do anything to disrupt that. The Pathways Community Hub not only contracts with agencies in the community, but goes out and contracts with funders that will support this network. That might be health plans, it might be grants, it might be contracts at the local, state, or federal government level, United Way. There's a variety of ways that Pathways Community Hubs bring in funding. And in addition, the Pathways Community Hub will work to find referral partners in the community that will help identify people that could benefit from the hub, and direct service providers that are going to actually be providing the services. So the next slide, I want to give you a little bit more detail about the Pathways Community Hub. This is now a nationally certified model. It is under, the certification is at the Pathways Community Hub Institute. And there are prerequisites and standards that need to be met for a Pathways Community Hub. One of the most important, it has to be neutral, transparent, and accountable. So a Pathways Community Hub can't favor one hospital over another, one health plan over another. It is Switzerland in the community. It's not playing favorites with anybody. It's very important that the hub is perceived that way. There's only one in the community or region being served, and it has to be located in that region. It's key job developing that community-based care coordination network. The hub does not employ community health workers. It reaches out to others, again, those CBOs, FQHCs that are in the community that already have community health workers and contracts with them. We use outcome-based contracting, and we'll talk a little bit more about this, but it's based around closing those pathways or eliminating risk. The hub must have a community advisory council, and that advisory council needs representation from all elements of the community, from people being served up to decision makers. The PCH agrees to use PCHI's model, and that means our data definitions, our data collection tools, and pathways. The next slide just gives you a little information on who can be a Pathways Community Hub and who can't be. Sometimes it's easier to start with who can't be. And you'll see at the bottom, if you're a hospital, a clinical integration network, a payer, a healthcare system, a statewide organization, you're not positioned to be a Pathways Community Hub because you don't have that neutrality. So what we find is mostly it's community-based organizations that evolve into Pathways Community Hubs. Sometimes we'll see health collaboratives or hospital associations. And more recently, we're seeing accountable communities of health evolving into Pathways Community Hubs. The next slide, switching from the hub a little bit, we're going to talk about the care coordination agency. Remember, the hub doesn't employ the CHW. It contracts with existing organizations within the community that they're the ones that employ the CHW and the CHW supervisor. But with the contract between the Pathways Community Hub and the Care Coordination Agency, there's an agreement to find any community member at risk, to use those 21 standard pathways, to agree to provide whole person care. Even if you're coming out of an agency that does housing, you have to know how to do all 21 pathways and be able to help people connect, and agree to the outcome-based payment methodology. It's important that these contracted agencies also agree to participate in governance and problem solving, because they're key, they're on the ground and provide a lot of information back to the Pathways Community Hub and the Advisory Council. The next slide gives you a little bit of overview of kind of the workflow that a community health worker within an agency would be walking through. We break it down to find, treat, measure. So community health workers find and engage individuals that are at risk in the community based on whatever the Pathways Community Hub decides is their target population. They build those trusting relationships. They do all of the connections to the services needed, and they use Pathways to track and track all of those completed elimination of risks. And they do a lot of teaching, and I'll show you some of our strategies that we use within the model, but so much of behavior change revolves around teaching. So they're very engaged in that as well. The next slide shows you the 21 standard pathways. And I could spend probably the next 3 hours talking about pathways, so I'll try to be quick on this, but these standard pathways are used across every Pathways Community Hub. No matter what state they're in, they're using the same pathways to track these risks, measuring elimination of risk. 3 of our pathways actually expand and have multiple codes under them, such as the medical referral pathway, the social service referral, and learning. Why we have set the pathways up this way: for the community health worker, the process is very similar, whether it's getting somebody to their dental appointment or their vision appointment. There's key steps they need to walk through. So the pathway itself is the same, we just have different codes for the type of services. The next slide will give you an example of some of the outcomes. So remember that each pathway ends in an outcome that's measurable and meaningful to the person being served. So for example, the employment pathway doesn't end just when the participant gets a job, it's that they're still working 30 days from the date of hire at that same job. We'll see that kind of play out with housing pathways, where it's not just moving somebody into safe, stable housing, they're there 30 days later. So this just gives you kind of a flavor of what those pathways look like. The next slide is our medical home pathway. And this is one of kind of the simpler pathways. That's why I picked this one, because it's used when somebody needs to have a place to go for ongoing care. So every pathway, when we talk about the structure of a pathway, there's an initiation step. And this is, what is the issue that we're addressing? And in this case, somebody needs a place for ongoing health care. The start date is when the community health worker first becomes aware that this is an issue. The person may have needed a medical home for the past 5 years, but today the community health worker, in meeting and talking with them, realized that this is a risk. So that starts the pathway, and the pathway stays open until that risk is eliminated, until that person has picked a provider, scheduled an appointment, done everything they need to do to get into that provider and completed that appointment. And now they're enrolled into that medical home. You'll see that every pathway ends with not only the CHW signature, but their supervisor's signature as well. This is a billable unit within our model, so it needs to have kind of that extra set of eyes on it. But this is what a standard pathway looks like. The next slide. This is a new development within the model, and we're really excited about it. But as I mentioned earlier, a lot of what community health workers do is provide learning. And we have developed, I think it's 48, soon to be a few more learning modules that community health workers use when they're working with their participants. And that's related to use with the learning pathway. And these learning modules are designed to provide evidence-based education, but also to use open-ended questions, motivational interviewing, and the ask, tell, ask methodology. The next slide walks through kind of how addressing individual risk factors leads to community level change. So when we start over on the left, we're addressing things like, do people have food and clothing? Do they have safe, stable housing? Do they have a job? Do they need help with depression treatment? By addressing those risk factors through the pathways and completing pathways, we can prove that we've connected people to the services that are really meaningful to them. They now have safe, stable housing. They're now food secure. They've had a normal birth weight infant. But as we watch Pathways community hubs over time, if they're truly reaching out to the most at-risk people in the community and closing these pathways, we start to see large-scale outcomes. We start to see reduced hospitalizations, reduced readmissions. We see improved medication compliance, cost savings, which is always big. So there's this continuum. Even though we're working at the individual level, we see community level change. The next slide. I want to stress again, this model started with community health workers, and community health workers remain the foundation of this model. We see them as partners, coaches, and advocates for their clients. And these community health workers can work in multiple places within the community. We have community health workers stationed in schools and churches, again, community-based organizations, federally qualified health centers. That doesn't matter so much. It's the work of the community health worker and the relationship and trust building that they can provide that's missing so much in many of our systems right now. The next slide. I want to go back a little bit and talk about funding around this model. So the Pathways Community Hub, again, contracts with each care coordination agency that employs those CHWs, but also goes out and finds contracts with funders and payers and grants and private philanthropy that want to support, that want to pay for pathways, that want to get to these outcomes. And a Pathways Community Hub that is strong and sustainable will build many, many, many types of funding to come in to support that infrastructure, which also supports and builds the workforce. Because as a Pathways Community Hub grows, we need more and more community health workers to do this work. The next slide gets into a little bit about how we do contracting. And again, I could spend a while talking about this, but just to give you an overview, every pathway has a unique code and modifier assigned to it. But not only that, the Pathways Community Hub Institute has developed what we call outcome-based units, which is basically a measure of how much work goes into completing a pathway, knowing that sometimes you start a pathway and they're not going to be completed. We don't have the resources, we lose the person, whatever the reason is. So you can see if we look at something like the housing pathway, we assign 15 outcome-based units to that, where we assign 5 outcome-based units to a developmental referral pathway. What that means is if you're a brand new Pathways Community Hub, you can take the contract template and just negotiate the value of one outcome-based unit. So let's say we pick $50 for one outcome-based unit. And then we complete an adult education pathway, 50 times 10, that's worth $500. So the contracting has been done in multiple states now. We can certainly help in Nevada develop some contracts as well. The key thing here is that 50% of the contracts have to be linked to completion of pathways. That's what's important to the person being served, that we're eliminating their risk factors. The next slide. I want to mention briefly about technology. Now, PCHI does not have a technology platform, and that was a decision we made over 5 years ago to just keep our focus on fidelity to the model. But we have developed certification for technology vendors. So the Pathways Community Hub Institute, this is one of our newer certifications, is working with technology vendors that want to support Pathways Community Hubs. It's a pretty intensive process for them to go through. We really need to see that they're able to support and track all of the data that needs to be tracked for a successful Pathways Community Hub. We have 2 technology platforms that are actively being certified right now. Care Coordination Systems has reached provisional certification, and Innovacer is close behind. We expect them to be certified within the 1st or 2nd quarter of this year. The next slide talks a little bit about, does the model work? So when I talked about the original study with just our community health workers and our own agency reaching high-risk pregnant women, we published that data in the Maternal and Child Health Journal, and that's over on the right. And what we were able to do, we gave 3 years of our data to the Department of Health. They matched it to birth certificates. Then they gave that data to the Ohio State University Department of Biostatistics, and they did a case control match by census tract. So as much as possible, we were looking at women living in the same neighborhood as the women that we were serving with pathways. What we found over that time period is a 60% reduction in low birth weight, which clearly translated into short and long-term return on investment. But what I found really fascinating with the data was that there was no difference in connection or use of OB care, but we saw that the women we were working with on average had 5 or more non-medical pathways. And those pathways were housing, childcare, transportation, employment, adult education. They weren't health-related issues per se. A more recent study on the left shows Centene in Ohio is called Buckeye Health Plan, and they looked at one of our largest hubs in Northwest Ohio. And they looked at women, their members who were pregnant that were connected to that hub. And they found that if they had a high-risk pregnant mom and she was engaged with the Pathways Community Hub, her baby was less likely to require NICU or special nursery care. And then they looked at the babies born to those moms, to all the moms. And overall, for the first year of life, looking at inpatient, outpatient, and pharmacy costs, they had a 236% return on investment. But if they specifically looked at the babies born to the high-risk moms, it was over a 400% return on investment. So clearly that's a win for the health plan as well. Better outcomes, cost savings. The next slide, and I'll just touch on this, it's just we have researchers working with Pathways Community Hubs across the country. We have developed a risk reduction research network that's really looking at those individually modifiable risk factors and how they combine and affect each other. But if we go to the next slide, I'm not going to go into this. I just want to point out, this is a picture of our website, pchi-hub.com. If you're interested in any of the articles, just hit the resource tab up at the top right. And if you're interested in seeing where hubs are, these are specifically certified Pathways Community Hubs. You can hit the Where Hubs Are Working tab and you can visualize that. The next slide shows where we're working right now. We're in 17 different states. Some of these states have certified Pathways Community Hubs. Some are close to having PCHs that are certified, and some are just beginning and just starting that journey. We clearly were hit by COVID-19 too, and that delayed some of our certifications over the past 2 years. The next slide, I just want to end with, why would a community want to do this model? You know, what's the value to the community? Well, this is truly a collective impact framework, and it's a community-driven approach to improve health outcomes. Because once you put the infrastructure in place, you can address a whole variety of issues with the Pathways Community Hub care coordination approach. The other thing is that the Pathways Community Hub manages all of the partnerships and contracts and quality improvement and reporting, allowing the organizations that employ community health workers to focus on what they do best, which is serving the needs of their residents and not worrying about contracts and reporting and all of that stuff. That's done by the hub. Also, this is an outcome-driven methodology. If we're tying 50% of the contract to actually achieving outcomes that matter to the community, that's a win. The next slide talks a little bit about how Pathways Community Hubs can leverage resources. Clearly, what we've seen is that Pathways Community Hubs, once they get established, they're very good at going out and finding resources for all kinds of things around housing, transportation, employment, other social determinants of health. They're very good at finding many different funding streams to support the network that they've built. And again, to really emphasize, this is a great strategy to develop the community health worker workforce. So the next slide talks a little bit about, why would a payer be interested in contracting with the Pathways Community Hub? Well, number one, it streamlines their work. Think about going into a community and doing one contract, but having access to many different community-based care coordination agencies employing community health workers. That's huge. And they know that if they contract with the certified Pathways Community Hub, that they have gone through all of the prerequisites and standards and are true to the model, and they know what kind of data they're going to get back. They also have limited risk. Again, 50% of the contract, they don't pay unless there's an actual outcome achieved. But also we find that payers really value being a part of this process, being a part of building a hub and getting to meet other decision makers and community members as they go to meetings and sit on the Community Advisory Council. Their members also benefit by all of the other resources that the Pathways Community Hub secures and brings into the community. More housing resources, more transportation resources, more employment resources. And truly, this is a population-based approach. If they have a member that they're serving that for some reason falls off of their plan, they're still going to receive care coordination. So if they show up a year later, they're going to have had services in between the time that they left and the time that they came back. But probably the most important is the next slide. Why would residents want to have a Pathways Community Hub? So here's just pictures of two of our community health workers with people that they've worked with. And on the left is Maisha, and she said, I'd still be homeless. I don't have a doubt. It was just a blessing. She didn't just help me and then leave me alone. Maisha was found by a community health worker living in a car with 4 kids. When her community health worker signed off, Maisha had housing, she had a job, all her kids were in school, they were all connected to healthcare. Things were going much better than when she was found. And for Judith's client over on the right, her statement, I didn't know these services existed. The help really goes deep. It's wonderful. And I think that sums it up really well. The help really goes deep. It's not just, hey, here's a phone number to call, or here, I'll check back, in 2 months. It's like, I'm your community health worker and I have enough resources and funding to make sure you connect to everything you need to get to be in a better place. So just to end, we'll go to the next slide. That's the end of my presentation, but I've got 3 questions for you as you go into your breakout groups. What interests you about the Pathways Community Hub Institute model? What did you find interesting about this? Number 2, how would the PCHI model align with work happening now in your community? And number 3, as always, what concerns do you have about the model? What are questions that have come up that you want answers to? So Brian, I'll turn it back to you.
Perfect. And we did have one question in the chat from Melissa. She asked if there are any existing partnerships with aging and disability resource centers, and if so, what does that look like? So before we get into the breakout sessions, Dr. Redding, if you could maybe address that real quick.
I don't know about resource centers, but we have several hubs working with like local area agency on aging that have community health workers that work out of their offices. So I'm not sure if that's close enough to what you're looking for, but we can talk offline too.
Perfect. Thank you. So for this next breakout session, it's going to be very similar to the first one. We'll break up into 5 groups with a Comagine employee in each one to kind of do the debrief. But we'd love to hear from you on these 3 questions. So any input or clarifications that you need, please ask, and we will do our best to answer the questions. And if not, we can refer them back to Dr. Redding once we come back to the larger group. So Manny and Lily, if you want to break us up, that would be great. All right, looks like everybody's hopping back in. We'll give them a few more seconds and we'll have a debrief. Perfect. Thank you, Lily. So we'll do the same thing as last time. And Tracy, if you'd like to start with your group, we can start there.
Yeah, we had a great discussion and we did have a question that came up. So I don't know if we can take 30 seconds. Maybe Dr. Redding would be best suited to answer it. So first I'll just share lots of good discussion, lots of questions just about the model, and the questions were really around, what kind of training the community health workers receive, what kind of education they need to come into the CCA having. And fortunately, we had Julie on our call from Dignity, so she was able to speak to that kind of in real time from the work they've been doing. And then we also talked very briefly about the new CHW Medicaid, or the legislation that has just passed and been enacted around reimbursement for CHWs. The question that did come up was really around the payment. And so I had shared that, the contracting happens at the hub level, and the hub really manages the flow down of the resources and the payment to the certified care coordination agencies, who then employ and pay the community health workers, and 50% of that payment arrangement needs to be outcomes based. Dr. Redding, I don't know if you can speak any more to the payment process or elaborate on that. That was a question came up, and if not, then we can certainly take it offline and do a follow-up.
Oh, yeah, no, I think, Tracy, you were right on target. So the contracts, so the hub is building a contract with a payer that's at least 50% outcomes based. And they're also building a contract with the care coordination agency employing the CHW that's outcome based. So that outcome based strategy runs throughout the whole network. But what we see over time is the Pathways Community Hub, usually they'll retain a percentage to do kind of all the things that the hub needs to do for reporting and quality improvement and contracting. But as the volume grows, the hub needs to retain less percentage because they have that many more people kind of funneling through the Pathways Community Hub. So it's a much kind of deeper discussion, but hubs that have been in existence for a while, we'll see that kind of that ratcheting down over time. And in some states, like in Ohio, there's actually funding from the state that supports a lot of the infrastructure of a Pathways Community Hub. So there's several ways to approach funding that we could get into.
Thank you. I think that sums up our group, Brian.
Perfect. Amy, would you like to go next?
Yeah, thanks, Brian. Really good conversation. A couple of the highlights was loving about the model. What they liked about it was the coordination piece, working smarter, not harder, and really collaborating and coordinating across the community. The fact that they changed the model, the initial model, to make it work, right? That it was individualized, the approach to really meet the need of the clients at the end receiving the service. Making sure that the recipients were in the correct box, and then providing that individualized care for them. The neutral model, the hub, no favoritism. Really appreciated that. A couple of people commented on that specifically. In regard to question 2, we're doing the work. Obviously room for improvement. The gap is the cohesiveness, and talked about really that's what is needed, that collaboration and that cohesiveness. And then the sustainability, that long-standing sustainability, the financial stability in order for these community health workers to provide this level of service and care. And then really no concerns about it, but long overdue. And one participant stated, if we can get this done before I retire, then it will have all been worthwhile. So really excited about it, and making sure also that we get the right stakeholders on the bus and also in the right seats to help us see this through, and it really being a community-based approach. I think that was it. That's the main points. We said a lot more, but those will be in the notes. So thanks, Brian.
Thanks, Amy. And I will turn it over to Dr. Reeves for your group.
So our comments were that, first of all, that the hub doesn't employ the community health workers. That was very interesting, that they're really a neutral convener and hub and coordinator on behalf of the whole community, as opposed to the community health workers only serving the needs or the priorities of the organization with whom they're employed. The other was that it's comprehensive. It really goes across and tracks the outcomes, measures the outcomes, reports the outcomes, improves the outcomes across a comprehensive array of unmet needs. Another commenter spoke of how this was holistic, and it was focused on what the patient or the client needs or the family needs, rather than what the employer knows or is expert at. So it's more on the terms of the beneficiary or the client's priorities. Another commented about how this simplifies contracting, because instead of contracting with 15 or 30 or 100 different entities to get all of these different 30, 50 or 100 different priorities addressed, you go to one place and you contract with that entity that coordinates across the full range of expertise. And then the last comment had to do with how this would really help their patients self-manage their condition, so that the patient's in charge and has the tools to succeed at taking care of their most important issues, because they have help across the range of the issues. So I took notes and took recording, but it was very excellent input by each of the participants in our group. Thank you.
Great. Thanks, everybody. We appreciate the participation there. And Lily, I'd check in with you, see if you had anything different to add.
Yeah, our group was mainly about questions that they had. One of them was regarding the value-based strategy and how that works and how it aligns with incentives. So I don't know if Dr. Redding has time to address that. And then the other was about information sharing and how that happens within the systems of care. So those are the main main questions. And regarding number 2, how would the work PCH model align with work happening in the community? They liked the navigation between the systems in the community. So Dr. Redding, I don't know if we have enough time for Dr. Redding to address that, but
Sure.
If we do, that'd be great. I'm sure they'd appreciate that.
Sure. So Lily, I'm going back to your first, and I got the one about information sharing. And so that, as you can imagine, anytime you're contracting with payers and hospitals and everybody else, that protecting personal health information is key. So, I mean, and that goes into the whole picking a technology vendor that is very, is compliant with HIPAA and high-tech secure and all of that, but also that a Pathways Community Hub develops their own release of information tool, and that no data is collected until that's signed. And that's across all of the hubs, until you've got that, clear understanding of what information is going to be gathered, that you don't collect anything. So there's a lot that goes into that, and some of the standards and certification cover that too. But I'm trying to remember what your first statement about was. Was it value-based payment?
Yes, the payments and how it aligns with incentives. Yes.
Well, the incentive is that if 50% of your contract's tied to the completing pathways, that really gets everyone kind of focused in on how do we eliminate these risks, right? So it's not just the CHW, it's the supervisor and it's the administration of that agency or CBO that's trying to figure out, how do we get these pathways closed? And I will say it's important. And one thing that wasn't actually in the original development of the model, but it's all around pathways that can't be closed, right? We call them finished and complete. We have to close them. We're discharging somebody, but we didn't hit the outcome. But what a Pathways Community Hub can do is look at all of that data and say, wow, this community health worker tried 10 different things to get this person safe, stable housing, and nothing worked. And they can start to gather all of that data and present it in a way to the community at large to say, we have a real problem here. And you might think that all these resources are working, but they're not. So it's a way that we've seen hubs drive policy change, which is very neat to see.
Perfect. Thank you, Dr. Redding. And we had one more question come through the chat, and we definitely have time to hit on that one real quick. So the question was, in other states where this model is used, are there concerns that these states have encountered with the duplication of payment by both the hub if 50% of the outcome is met and Medicaid?
Well, usually the hub is contracting directly with So this is payment for community-based care coordination services. So if you're a direct service provider, you get paid the same way you always get paid. So this is specifically payment related just to the connection of a person to a needed service. So there's no like double payments anywhere, but we can kind of map that out and take a closer look if that would be helpful. But yeah, no, that wouldn't fly in any of the states we work in.
Perfect. Thank you. And if there's continued questions, please feel free to enter them in the chat. We do have some time built in at the end of the presentation as well, which we're almost there. I just wanted to debrief for our group real quick. Mark Domingo brought up some very good points that I wanted to share. He brought up the point that this model allows the community health workers' work to be tracked, where currently in a lot of agencies, the community health workers are doing all this great work, but there's really nothing to show for it other than linking up a person and then they don't see them anymore. But with this, we're actually tracking the outcomes. We're collecting all of the data and it's going bilateral both directions. So that's what he really liked about it. And also the sustainability of it. So, a lot of community health workers are grant funded. Once the grants end, they kind of move on to the next project. So with this Pathways project, the idea is sustainability. So that was one other thing that we hit on in our group. And with that, I believe, Lily, we can move on to the next slide. And like I said, feel free to keep putting any continued questions in the chat. And we do have some time at the very end to hit on that as well. And I will turn it over to Tracy.
All right. Thanks, Brian. So we just wanted to take a few minutes here as we're nearing the end of the call to kind of share with you all where we're at and where we're going over the next kind of the rest of 2022. So we are really, I would say, doing that first bullet today of bringing you all together to start this conversation. We've our team's been hitting the pavement for a couple months now in both identifying the partners that needed to come today, and I think there's also a strong possibility that there are more folks that should be at this table that perhaps we haven't surfaced yet, and so we would love for you to share, and I think we have an opportunity for that in the follow-up survey that Brian will be talking with you more about in a bit. But we've been having conversations and we're really at the start of this journey, if you will, in bringing you all together to assess readiness and really build engagement around the opportunity to bring this evidence-based model to Clark County. So over the next few months, we will be continuing to identify the organizations that need to be involved in this work, and specifically those that are interested or kind of ready to go in becoming a certified care coordination agency. And we'll be forming our core team, which Brian will be speaking a little bit more to in a moment. And then kind of our other big to do in 2022 is to find this follow-on funding. So we are currently operating on a one-year planning grant to get this work started, to create the community table and bring this core team together to start launching this work. And then if we are successful, as we hope we will be moving into kind of full implementation or phase 2 of this work nearing the end of 2022. But we definitely cannot do this without all of you. And so before we jump to Brian to talk a little bit more about the core team and other next steps, I do see some questions jumped into the chat. Brian, do we have a moment to address these before we continue?
Sure.
Okay. So how effective has this model been in reducing disparities? Some populations have significant health disparities, and how will implementing the model make an impact? So Dr. Redding, would you like to jump in?
Yeah, that's really one of the whole reasons why we started the Pathways Community Hub model. And I'll tell you, in Ohio, where we have soon to be 11 hubs, we've got about 85% of the state covered by Pathways Community Hubs. Our biggest supporter is the Ohio Commission on Minority Health. And they really see Pathways Community Hubs as their leading strategy right now in the state to address health disparity. So, so we hope we're hitting on that.
And the next question was, what data systems do other PCHs use?
Well, again, we're doing the certification of technology vendors. I'll tell you, most of the hubs are on care coordination systems or Innovator at this point, but we're open to any technology vendor that wants. We're agnostic towards them. So as long as they can show us they can do what's needed to be done to support a Pathways Community Hub, we're happy to talk to any technology vendor. And there's quite a few that are kind of in the pipeline right now, but they're just not as far along as those two.
Yeah, and just to kind of follow up on that point, I think it really depends on the needs of the community and depending on who you're contracting with, there might be different needs based off of who you're working with. So you really have to find a technology vendor that works best for the groups that you're engaged with in the hub. Perfect. And Lily, if you want to go ahead and move to the next slide. So Tracy hit on this a little bit earlier about the core team. So this is going to be really our next deliverable for this project. We want to form this core team to help get some of this work stood up. So we hope to be forming this core team in the very near future. We're hoping to create a team of anywhere 5 to 8 individuals from a variety of backgrounds in the Southern Nevada community. So we want a diverse group of folks, potentially somebody from the payer world, potentially somebody from the health district world, and then some community-based organizations as well who are actually that boots on the ground service delivery partners. We want to get as many different, backgrounds as possible there so we can stand up this hub, identify what our target populations are going to be, looking at some of the data, and then having these conversations with all of the other agencies in Southern Nevada so we can see what the biggest needs in the community are. The purpose of the core team is to help steer the direction of the hub. It will also be used to identify those priority areas, which we hit on. So that's going to be one of our next steps. So in the SurveyMonkey link that's going to go out after the call, that is one of our questions. If you have any interest, please let us know and we can set up some time to talk to you in more detail. The time commitment on this for the most part for other hubs has been about 3 to 6 months. A lot of them meet bi-weekly for an hour to 2 hours. So not a major time commitment by any means, but we do want folks who are going to be very invested in the project and have a stake in the project as well. So just wanted to put that on everybody's radar. So please provide any feedback you have to us in the survey after the call. And go ahead, Lily, next one. And then we did hit on the legislation and some of the breakout groups as well as earlier on, but we just wanted to keep this on everybody's radar. There was a bill, AB 191, that was passed recently in May of 2021, became effective on July 2021. And this bill requires the state plan for Medicaid to include payment for the services of a community health worker. So this is something that hadn't existed in Nevada previously, and we thought it was just really important for the sustainability and the future of community health workers in the state. So we think this is good timing with some of the projects that we're looking into. So if you have any questions about the bill, I do have some additional information on it, and a lot of the text is available free online. So if you have any questions on that, take a look at it. It is very interesting to see how this is just getting rolled out. They're very early on in the stages there, but we wanted to make everyone aware of it. And go ahead, Lily. So as we're getting ready to close up here, we just kind of wanted to keep it on everyone's radar that there will be a follow-up survey set out. And we'd love as much feedback as possible. If there was any questions you feel didn't get answered during the presentation, please let us know and we'd be happy to set up some time and meet with you one-on-one if your agency may be interested in this project. So don't hesitate to reach out. I also have my contact information on one of the slides coming up, so feel free to reach out to me directly and I can link you with the appropriate person. Go ahead, Lily, next slide. So that's all we had for today, but we do have some additional time if anyone has any follow-up questions before we close out here. And like I said, if not, please feel free to call or email me and I can link you with the appropriate person. So we will pause there for any questions. I see a comment in the chat that CHWs may begin enrolling with Nevada Medicaid as of February 23rd, 2022, which is just around the corner in the next week or two. Thank you, Breeza. Awesome. Well, if there is nothing else, we will go ahead and close out for the day. We really appreciate everyone's time. The turnout was fantastic when we were first starting this. We did not think we would get 90 people to show up to this. So really thankful for everybody's time on this Monday, and we hope you all have a great week. And please reach out with any questions or concerns. Thanks, everybody.
Thank you all.